Good afternoon and welcome to Clinical Pearls. I'm your host, Curry Bordelon. Please join us by typing your question in the chat box below. Today I'm honored to have Mary Grace Cox, the Sepsis Program Manager for UAB Hospital. Mary Grace's nursing role includes coordinating quality improvement efforts to improve patient outcomes. Thank you for having us today.
Thank you. Appreciate it.
So as we get started talking about sepsis and your role within UAB healthcare, dealing with quality improvement initiatives related to sepsis, what is sepsis?
So sepsis is basically the body's reaction to infection. And it can look a lot of different ways, but it's your body's way of telling you something is not right. There's always an underlying infection related to sepsis. So you can't have sepsis without an infection. So that's basically what sepsis is.
So are there different types of sepsis, or is it only one type?
Sepsis basically can exist along a continuum, and so there's different levels of severity of sepsis. And so you can have basic sepsis, which could look like maybe having a fever or an increased white blood cell count, or maybe even an increased heart rate. And then it can progress to severe sepsis and even septic shock, where your organs are affected by the underlying sepsis.
So you talk about severe sepsis, which is quite scary to a lot of people. Can you talk a little bit more about that?
Yeah, so basically when sepsis starts getting more serious, your organs start to be affected. And that's why we like to act very quickly with sepsis, so that we can prevent it from becoming severe or even progressing into septic shock.
Which is very important to be able to identify early to be able to treat effectively.
Right, exactly.
Can you talk about some of the clinical manifestations of sepsis?
Yeah, so there's lots of different ways to identify sepsis. It's very difficult though, because there's not one clinical test or indicator that says this patient has sepsis. And so we use a lot of different clinical indicators to say that this patient might have sepsis. And so we use things like SIRS criteria, which are basically there might be an inflammatory response happening, which consists of white blood cells and things like that it could indicate infection. We could also use measures that might indicate organ dysfunction related to sepsis or infection. And so those things would look like maybe an altered mental status. A patient might be more confused or a little bit more sleepy or lethargic. A patient's respiratory rate might increase, or their blood pressure might decrease as well.
So you make mention about how difficult it is sometimes to identify sepsis or to effectively identify it so you can treat it effectively. What makes it so difficult to identify?
I think because sepsis can look like so many other different clinical issues. Say if a patient has multiple comorbidities where there's lots of things that could increase a patient's respiratory rate, right? It's not just sepsis. Other conditions like coming in with a trauma, a patient's heart rate would be elevated, their white count would be elevated from the stress of the trauma. And so that's what makes it difficult to identify, is there's not one key clinical indicator that says this patient has sepsis. And so we really just have to kind of put all the pieces together and communicate effectively as a team to think about sepsis critically.
So how big is the problem beyond just the healthcare setting? Because I know it's quite substantial. Patients could stay in hospitals longer, they can have comorbidities, they can also have mortality rates that increase. How big is the problem nationally?
So nationally, we see easily over 1 million cases of sepsis every year. As far as mortality goes, it's well over 250,000 patients a year die from sepsis in the United States. So it is a significant public health issue in the United States and globally too. Do
you know how many of those patients were in treatment at the time of sepsis?
I don't know off the top of my head, but I could bet that a lot of them were. Once we start treatment for sepsis, there's odds are that we'll have good patient outcomes, but sometimes we don't recognize it as early as we should. And so that's where we see, some changes in mortality when there's late recognition after identifying the source of infection.
So for most of those patients who have sepsis or identified sepsis, are they already currently patients within a healthcare facility or system, or they come into facilities with already sepsis?
From my experience and from looking at within the health system of UAB, 80% of the patients that we treat with sepsis come in to the hospital with sepsis. So they've developed it in the community and they're coming to the hospital already septic. The other 20% of patients develop sepsis in the hospital, or we would call sepsis not present on admission, but the overwhelming majority have sepsis as soon as they hit the door, typically of the emergency department.
Are there certain populations that are more at risk when it comes to being susceptible to sepsis?
Yeah, we see that, of course, the old and the young typically are at risk for a lot of different things. Their immune systems might not be working the same as maybe someone in their 20s to 40s to 50s. We also see, of course, patients that are not able to mount an appropriate immune response. So patients with cancer that might be on chemotherapy or immunotherapy, or patients that have rheumatologic disorders that might also be on medications that might impair their immune system to work effectively.
So we know, in the United States, we talk quite frequently about antibiotic use and overuse or underuse of antibiotics during certain disease processes or infections and so forth. How can we distinguish when is too many antibiotics enough, and how does that play into the risk for sepsis?
Yeah, that's a really difficult balance and one that we talk about a lot in healthcare. I think that, of course, antibiotic stewardship is very important and something that physicians and pharmacists are constantly communicating about, trying to make sure that we don't mount resistances to antibiotics. But on the flip side, if your provider, if you're a patient and receiving antibiotics, or if you're a healthcare provider administering antibiotics, we want to make sure that we deliver the full dose of antibiotics to make sure that the infection is completely eradicated. And a lot of times we'll see, patients say, oh, I feel better, so I don't feel like I need to finish my antibiotics. But we always want our patients to finish their antibiotics to prevent the likelihood of sepsis developing.
So based on your role, you deal with a lot with quality improvement initiatives, specifically related to infections and sepsis at UAB Hospital. So let's talk a little bit about that function, that role that you have.
Yeah. So as a nurse, I function among a team of other nurses that works on other various conditions, but I'm all sepsis all the time, so I work just on sepsis. We have another sepsis coordinator now that works with me, and we work under our director who guides us in quality improvement principles to address some items that are specific to sepsis. But one of the biggest things that helps us in that journey is engaging with a multidisciplinary team. So nurses, pharmacists, physicians, advanced practice providers, PCTs, all to get their input on how their workflow is affected by the things we put in place. And so we use feedback from them. We do, lots of observations of what goes on in the clinical setting to make sure our patients are getting the best care and that our staff are set up for success for delivering the best care.
Let's spend a little bit of time talking about teamwork. You mentioned something very important because something of this substantial impact has to have the team approach, especially the interprofessional, interdisciplinary team approach. Let's talk about some of the strengths and weaknesses and how have you been able to overcome some of the obstacles with team function?
Yeah, so I can say from my clinical experience, and I think this would be similar for a lot of other nurses and really any other healthcare provider, is that we often operate in silos. So physicians will work with other physicians to deliver care. Nurses will work with other nurses to deliver care. But we see the best outcomes when we come together as a team to deliver effective care and safe patient care. And so one of the things that we always stress is for a multidisciplinary approach to sepsis. And so we use a lot of different tactics to encourage teams to work together in that fashion when normally they might not.
Excellent. So can we talk a little bit about whenever someone presents to the facility with presumed sepsis or possible sepsis, do you have any sort of protocol or guideline? What does that enact? What series of events occur after that?
Yeah. So kind of the first line of defense is the recognition piece. And so depending on where the patient enters the hospital, whether they come through the emergency department, if they're an outside hospital transfer, We have a set of screening tools that help staff identify sepsis early. These screening tools, similar to how we diagnose sepsis, are not perfect, and so they don't always recognize it, but we do have them in place to help staff think sepsis as soon as the patient walks in the door. And so we use a screening tool in the emergency department and in the acute care setting called QSOFA, which in the literature says that it helps identify sepsis earlier. And it looks at several different criteria that the nurse can quickly assess right at the bedside.
So how does the training occur? So whenever you want to activate the protocol, you want to make sure all different entry points are aware of the recognition of sepsis early to be able to activate the specialized team. How do you get that information to those entry points?
Right. So we do have a process called code sepsis. So when sepsis is recognized, whether using the screening tools we have in place or just the clinician's just general intuition about, I think my patient is septic, we deploy code sepsis, which brings a critical care nurse and physician and a pharmacist to the bedside to partner with the primary team to deliver care. And so as far as training and educating in a place like UAB is really difficult because it's so large. But we've teamed up with our colleagues in the Office of Interprofessional Simulation at UAB to really get a more hands-on learning experience for how to engage the code sepsis process and follow it through, and really touches a lot on the teamwork and communication that we talked about before. And so that is one of the ways that I think is the most effective way to deliver that information. And then, of course, we use a lot of different other tactics to get that information to the staff that need it.
You touched on something very important, especially in healthcare and academic centers such as UAB, about the use of simulation. Can we talk a little bit more about simulation and how that is helpful for you when it comes to this specialized area?
Yeah, absolutely. So like I said, I think it is our the most effective way to deliver education within the sepsis structure currently. We partner with our colleagues in simulation to design the case specific to what the learners typically encounter in their clinical area. So if we're educating medical nurses, we want to use a medical case with a medical issue as opposed to surgical. And so we select learners that typically work together, so nurses and residents and PCTs would come together and work through that case together. We've partnered on a specific project called tabletop simulations, where it's more of a discussion around a table about the care of a septic patient, and we also utilize the electronic medical record so that they can practice using the medical record as they're caring for their septic patient. So it's really an effective way of educating adult learners specifically.
And what kind of outcomes are you seeing with this training?
So from the data that we collected about a year ago, we did see that our providers, so our our advanced practice providers and our residents use the standardized order set more frequently. And we actually saw better patient outcomes. So there was decreased mortality within the set of patients that are typically cared for by those providers. And so we saw great outcomes kind of objectively, and even just subjectively. Reading the comments on the evaluation forms, they say, I like this way of learning. I like a hands-on, high-touch way of learning. And so we're working to expand that to other areas of the hospital.
So we talk a lot about the role of nurses. And I want to get back in just a few minutes to talk a little bit more about QI, but we talked about nursing a little bit as we've during our discussion here. Tell me a little bit more about the importance of nursing in this whole process.
Yeah. Well, of course, nursing is key in this process. Nurses are the ones, I think, that spend the most time with the patient throughout a shift. And so they're going to be the first ones to notice a change. So I think really nursing along with our patient care technicians when we have them are really, kind of that front line of, do I think my patient is septic? And so getting that information from the PCTs for the nurses to analyze is critical. So there's the recognition piece that's so integral for nurses to understand and to critically think about. But then there's also the escalation piece. So I have this information, I think my patient is septic, what do I do next? And so having the confidence and the clinical judgment to escalate to the next level, so calling your provider, calling a code sepsis, and being confident in that is something that we're really trying to educate our nurses about.
So how receptive are the other not necessarily just the sepsis team, because
Yeah.
obviously they're quite involved in this
Absolutely.
process, but others around not part of the team. How receptive are they to that escalation element?
Yeah, I think it varies like anything else. I think that sometimes, clinicians might wonder, well, this is my patient. Why did you escalate care without me? But I think, and this is something that we touch on in our simulations quite a bit, is people's mindset about escalation. And so I think that when initially you might think, well, why did you escalate without talking to me first? It turns more into, okay, well, you needed someone right then and there, and I wasn't available. So I'm glad that you did escalate. But then other people are just really glad that there were other, hands and eyes there ready and willing to assess the patient. Another great thing about our response system for sepsis is that it's bringing critically care trained staff to the bedside. And so typically on an acute care floor, they can't deliver the same type of care that a critically care trained clinician can. And so once they see the value in that, once they kind of see that process, either in simulation or in real life for the first time, I think that's really helpful.
Are there any barriers that you can think of that potentially might slow down that activation process or keep someone from escalating the sepsis concern?
I think what I hear most often, especially from nurses, is, well, I just wasn't quite sure. I wasn't 100% confident this patient has sepsis. And I understand that. I mean, I've been a bedside nurse. I totally get that. And what I like to stress to nurses is that nobody is ever sure of sepsis. We're not sure until we have a confirmed, blood culture or whatever the source of infection is, that the patient was actually septic. And so even if you might not feel confident that you can, accurately diagnose this patient effectively, nobody else is either. And so we just like for our staff to have a very low threshold for escalation, because the worst thing that it can do is say this patient isn't septic and that's it.
Right.
But odds are, even if the patient isn't septic, something clinically is changing with that patient that needs to be addressed. So if it's not sepsis, it's something else that needs to be taken care of.
Some other sort of complication that might be masking itself. So either way, the patient receives the care that they need based on those findings.
Yeah.
It's very interesting to hear how integrated it is into units, how accepted it is, and so forth. Of course, there's barriers like we have with all clinical issues to that, whether it be escalation or whether it be any other type of clinical situation. What kind of resources do people have outside of the healthcare system? Because you have a very robust training system, training process, simulation, and so forth, and an escalation process. But what happens to other facilities who don't have that well-scripted or well-designed opportunity? How can they get resources to be able to improve their sepsis rates?
Yeah. So I know that the CDC always has great information about sepsis for caregivers, for providers, and for patients as well. And then also the Sepsis Alliance is a great organization that provides education material for healthcare providers and for patients and families. The founder of the Sepsis Alliance, his daughter actually was a victim of sepsis several years ago from a procedure that she had. And so the founder of that organization is 100% dedicated to decreasing sepsis-related deaths in the United States. And so those are some great resources if someone wanted to access those on their own.
Are there additional certifications or education that can be focused beyond just internally? Formal certifications that you can obtain from infectious disease in general?
Not that I know of for nursing specifically. That sounds really cool, though. I'll get right on that. That sounds really neat.
In
but
your
there's,
spare time.
yeah, exactly. But there's lots of resources online. There's so many articles in different nursing and quality and medical journals about those kinds of things. I don't know that there's a specific certification as of right now. But there's so much information out there on kind of the pathophysiology of sepsis and how to treat it effectively.
Can we talk a little bit how you might incorporate families? How do you involve families in this process?
Yeah. So last year we did a project with specifically patient and family education and found that oftentimes the patient is focused on just getting better. They're kind of overwhelmed with the healthcare environment. So we really focus on the families and the caregivers for, watching out for signs and symptoms of sepsis. Because one of the signs and symptoms of sepsis could be confusion. And so we need to rely on these family members that know their spouse or their child or their parent well enough to say something isn't right. And then arming them with the confidence to call their doctor and say, I'm concerned about sepsis. Use the word sepsis, even if you don't know for sure. Say, I'm concerned about sepsis, and that will definitely kind of kick things into action a lot more quickly.
Thank you. So as we continue to talk about sepsis and how it affects patients, inpatient and so forth, after that patient is treated, what type of long-term complications might patients see?
Yeah. So there is something called post-sepsis syndrome, which we don't know tons about, but we have seen that there can be some long-term consequences from having sepsis, and especially from having severe sepsis or septic shock. Unfortunately, a pretty common complication with sepsis is amputations from being on, say, vasopressors for a long period of time, or even from just having poor perfusion to your extremities. So that's certainly an unintended consequence of having sepsis. Other things can be just kind of confusion, lethargy, other things like that, where the patient just doesn't feel like themselves, and that can continue for quite a long time.
Excellent. So we have a question from our audience. Can you tell us more about if this is a nurse-driven process or provider-driven process?
That's a great question. We've set this up to be primarily a nurse-driven process. We know that our nurses are truly on the front line, in and out of their patients' rooms all day for 12 hours a day. And so we wanted to arm them with the tools to be able to escalate on their own. But certainly anyone can call a code sepsis, a provider, an APP, whomever. But this truly is a nurse-driven process at UAB.
Excellent. So most conferences have some elements of pharmacy, along with some infectious disease type of breakout sessions and so forth, especially that are population specific. Have you ever participated in some of these conferences where you spread some of the great work that you're doing and talked about some of the activities?
So we are actually going to a conference this month, just in a couple weeks. We're going to Las Vegas to present on the simulation project that we've done. A couple of years ago, my colleagues presented on the code sepsis process itself at the same kind of conference, and we're looking forward to going back to that conference again. There's a lot of great sessions there.
What kind of reception did you get from the participants?
I think that they are particularly impressed that it is a nurse-driven process, truly. And then also that we do screen so frequently for sepsis. At other organizations, I think that it's closer to maybe every 12-hour screening, so maybe once a shift or a handoff. But at UAB, we screen every 4 hours, which catches some changes in vital signs that we might not otherwise identify.
Excellent. So we have another couple questions from our audience. Have you seen a decrease in overall mortality?
Yes. Directly after we initiated the code sepsis process back in 2016, we saw an increase, of course, in the utilization of the processes that we put in place. So using the code sepsis escalation pathway and utilizing the standardized order set for the providers. And with the increases in those processes, we saw a decrease in mortality and the number of sepsis-related deaths. And as many things, the longer we get from when they were pushed out, process utilization might creep down a little bit, and we saw a subsequent increase in our mortality again. And so that's something that we've used to really say, hey, this process works, and then when we use it, we do see great outcomes with it.
That's excellent. Yeah. So our last few minutes that we have together, any last minute words or any other resources that you want to provide?
Yeah, I would say for nurses and nursing students, escalate and be confident. Think critically, don't just use the screening tools that you have, but escalate confidently. And then for patients and family members, I would just say also the same thing, escalate to your physicians early.
Excellent. Yeah. Well, thank you so much for joining us today. I appreciate it. And thank you for the audience and sending in some questions. We look forward to hearing from you next time.
Thank you.
If you liked this video, please remember to like and subscribe and click the bell icon to get instant notifications when we release new videos. For more information on how to get CEU credits or for more on the UAB School of Nursing in general, check out the description below. Thanks for watching.